Welcome students. Today I'll be giving a talk on anemia in pregnancy. So let's start. The learning objectives for this talk will be to diagnose anemia in pregnancy, learn the effect on mother and fetus, learn the signs and symptoms of anemia in pregnancy, also to learn prevention of anemia, to know the supplementation of oral iron during pregnancy, how to manage a case of anemia during pregnancy, what should be the management during labor and delivery if a woman who is anemic comes to the labor room, nutritional anemia control program, and also the postpartum contraception. So anemia is one of the commonest disorder in pregnancy. Prevalence in India and also in Pakistan varies between 50 to 70%, and the prevalence in USA is 2 to 4%. Nutritional anemia or the iron deficiency is the commonest form. And we can also say that anemia is the most important contributor to maternal and perinatal morbidity and mortality as a direct or an indirect cause. Anemia is defined as a condition where circulating levels of hemoglobin are quantitatively or qualitatively lower than normal. In a non-pregnant woman, if the hemoglobin levels are below 12 gram percent, then it's anemia. But in the pregnant woman, according to World Health Organization, if the hemoglobin level is less than 11 gram percent, then it is labeled as anemia. Or the hematocrit is less than 33%. According to the Center of Diseases and the pregnant woman, if the hemoglobin level is less than 11 gram percent in the first and the second and in the third trimester, that would be labeled as anemia. And in the second trimester, if the hemoglobin level is less than 10.5, then she will be called as anemic patient. Indian Council of Medical Research also defines the severity of anemia on the hemoglobin values. It will be mild anemia if the hemoglobin levels fall between 10 to 10.9 gram percent. It will be moderate if it is between 7 to 9.9, severe if it is less than 7 gram percent, and very severe if it is less than 4 gram percent. Now coming up to the causes of anemia in pregnancy. What could be the causes? So most important is the nutritional deficiency, and there comes the iron deficiency anemia. Again, if before getting pregnant mother has a poor nutritional status, then more likely chances then this nutritional deficiency will continue in pregnancy and she would have low hemoglobin levels. Beside iron, folate and B12 deficiencies are also important, and we will talk about that later. Chronic blood loss due to parasitic infections like hookworm and malaria, multiparity, and also if there is the interval between the pregnancies is less, multiple pregnancy, acute blood loss during any pregnancy like antepartum hemorrhage, postpartum hemorrhage, recurrent infections, urinary tract infections. They also cause anemia because of impaired erythropoiesis, which is formed in the kidney. Hemolytic anemia is seen in the cases of pregnancy-induced hypertension, hemoglobinopathies like thalassemias and sickle cell anemias, and aplastic anemia is rare. Now, pathophysiology of nutritional anemia in pregnancy. There is augmented erythropoiesis in pregnancy. We all know the physiological changes which occur in the pregnancy. The blood volume increases to 40 to 45%. There is increase in the plasma as compared to the red cell mass. That leads to hemodilution and decrease in the hemoglobin levels. Iron stores are depleted with each pregnancy. Too soon or too many pregnancies result in higher prevalence of iron deficiency anemia. There is extra iron requirement and loss during pregnancy. During pregnancy, total of around 800 milligram to 1000 milligrams of extra iron is required. About 300 for the fetus, 50 for the placenta, 400 to 500 milligrams iron is required to increase red cell mass. Plus, there is blood loss, 250 milligram during delivery and 220, for example, for the basal losses. Though there is conservation of iron also about 400 milligrams, because during 9 months of pregnancy there is no menses, and also there is contraction of blood volume after delivery. So if we plus all the numbers in the columns and then we subtract 400, so around average 800 to 1000 milligram of extra iron is required. Now we must know what are the factors which are required for erythropoiesis. Proteins are required for the synthesis of globin, minerals, iron for the synthesis of heme. Also hormones, erythropoietin, which is produced from kidney, it stimulates the stem cells in the bone marrow. That's why if there is problem in the kidney, like we said, repeated urinary tract infection, then the hormone level is affected and there is decrease in erythropoiesis. Other hormones, thyroxine and androgens. Plus, we also need trace elements like zinc, which is very important for protein synthesis and nucleic acid metabolism. Cobalt and copper are also the trace elements which are required. Vitamins, vitamin B12 required for the synthesis of RNA in early stage. Folic acid is required in later stage for DNA synthesis. Vitamin C is necessary for conversion of folic acid to folinic acid, and it enhances absorption of iron from small intestine. Pyridoxine, that is a B6, is useful adjuvant in erythropoiesis. And vitamin A is required for cell growth, differentiation, and maintenance of an integrity of epithelium and immune function. Now we will talk about the pharmacokinetics of iron and the daily requirement. And as you can see in the diagram, the daily diet contains around 10 to 20 milligrams of iron. Then how much is absorbed? 1 to 2 milligrams of iron per day is absorbed. And then it is through the transferrin, the iron is then transported, and we can see that it is going to the bone where hemoglobin is formed and erythropoiesis takes place in the bone marrow. And also the stores are in the liver and the heart in the form of ferritin and also other processes. And so this is now here the iron is being formed and also stored. There's also loss of about 1 to 2 milligrams of iron per day from desquamization of epithelium. Normal diet contains about 14 milligram of iron. Absorption is about 5 to 10%. That is about 1 to 2 milligram. 3 to 4% in the pure vegetarian diet. Additional daily iron demand in early pregnancy is 2 to 3 milligram per day. In late, it is 6 to 7 milligram per day. That is additional to 14 milligrams. So daily supplementation of 40 to 60 milligram of elemental iron is required during pregnancy, because out of that also only 5 to 10% would be absorbed. Folic acid requirement is also increased because that is also one of the factor which is needed to increase the erythropoiesis. In strict vegetarian, vitamin B12 also becomes deficient, and sometimes we need to give supplements of vitamin B12 too. Now we're coming up to the clinical features of anemia during pregnancy. You can see this chart. We have divided into symptoms and signs. Now symptoms could be if the patient, you can see that there's skin on the skin, we can note that there is paleness, coldness or yellowing. In the eyes also yellowing and pallor. Respiratory symptoms could be that the patient would complain of shortness of breath, weakness, change in the color stool. Central symptoms could be fatigue, dizziness, fainting, low blood pressure, palpitation, rapid heart rate, that is called tachycardia, chest pain, angina, heart attack, and severe anemia. And also in the abdominal examination, if it has been a very chronic anemia, there could be spleen could be enlarged as well as the liver. Now, signs you could see pallor in the conjunctiva, tongue, palate, nail, palm, and in the vaginal mucosa. Colonekia, that is the spoon-shaped nails, dryness and roughness of skin, brittle hair, glossitis, stomatitis, pedal anemia, edema, raised jugular venous pressure, and that is when there is heart failure. Pulse is tachycardic, collapsing pulse, blood pressure, postural hypotension. In the cardiovascular, you could have tachycardia and soft systolic murmur. In the respiratory, tachypnea, fine palpitations at bases of lung. Abdominal examination may reveal hepatosplenomegaly. So again, just a revision of what we talked about, that the clinical presentations depend on the severity of anemia. The high-risk women could be adolescent, multiparous, who have multiple pregnancies or lower socioeconomic status. If it's a mild anemia that we talked about from when the hemoglobin is between 10 to 11, less than 11, and then a patient could be asymptomatic. But if there is moderate to severe anemia, then the symptoms can vary from like pallor, weakness, fatigue, dyspnea, palpitations, swelling over the feet and body. And then signs could be pallor, facial puffiness, raised JVP, tachycardia, tachypnea, clefts in the lung bases, hepatosplenomegaly, pitting edema over abdominal wall or legs, hemic murmur, cardiac failure, and then glossitis, stomatitis, gelosis, brittle hair, and also colonekia. Now, what are the effects of anemia on pregnancy and the mother? We earlier also mentioned that it is one of the very important cause of perinatal morbidity as well as mortality, as well as maternal morbidity and mortality. So anemia affects both the mother as well as the fetus. First, we will talk about the effects of anemia on the mother. It has been seen if there is anemia, there is higher incidence of pregnancy complications like preeclamptic toxemia, that is the pregnancy-induced hypertension, preeclampsia and eclampsia, abruptio placenta, and preterm labor. Also, the mother is predisposed to infections like urinary tract infection, puerperal sepsis. There is increased risk of postpartum hemorrhage, and that we have contributed because of when there is anemia, then there is proteins are also less, so myoglobin is less, and that is deficient in the muscles, so the uterus muscles won't contract, and there is increased risk of postpartum hemorrhage, subinvolution of uterus, lactational failure, and maternal mortality due to congestive heart failure, cerebral anoxia, sepsis, and thromboembolism. There are effects of anemia on fetus and neonate. There are higher incidence of abortions, preterm birth, intrauterine growth restriction, intrauterine death, low Apgar at birth. Neonate is more susceptible for anemia and infections, higher perinatal morbidity and mortality, and anemic infant would have a cognitive and affective dysfunction. Most critical period is between 28 to 30 weeks of pregnancy, then in labor, immediately after delivery, and earlier puerperia. Congestive heart failure is failure to cope up with pregnancy-induced cardiac load. So this is the most common and grave complication of anemia. That is the congestive heart failure. Now, if you when we are seeing the woman who's pregnant and has come to our antenatal clinic, obviously first we take the full history, and we calculate the estimated date of delivery, and also we take the history of present pregnancy. So in this, if we from the history, we can see if the patient is has any risk factors that she could be anemic. So again, age parity would tell if she have had many pregnancies and there was less interval between the pregnancies. What is her diet? Any history of any chronic bleeding? For example, she was having bleeding during in the last pregnancy, antepartum hemorrhage or postpartum hemorrhage. or maybe her periods are very heavy, a history of any worm infestation, chronic malaria, and which race does she belong. Then when we examine, we could see if there is, again depending on the type of anemia, if it's moderate or severe, we could see the patient is pale, there is glossitis, splenomegaly, jaundice. These are mostly in hemolytic anemia, purpurea, and evidence of chronic disease, and anasarca and signs of cardiac failure in severe cases. So depending when you take the history and when you examine, and then you would know that there is the mother is anemic and we need to do a workup. So what investigations will we do? Depending on the basic first test is to know the we do the blood complete picture, and important is to know the hemoglobin and hematocrit. So it is noted at first visit, then 28 to 30 weeks, and then at 36 weeks. Sometimes we need to get repeated. For example, if the mother was anemic and we have prescribed her any medication, so maybe we would like to have again check her hemoglobin levels in between these gestations, like between 30 and 36 weeks. Maybe at 32 weeks or 34 weeks we would advise her to bring her hemoglobin level on next antenatal follow-up. Also, this is important because when we get the hemoglobin and the blood complete picture, we would know what type of anemia is it. Is it microcytic, hypochremic? Is it macrocytic? Is it dimorphic picture, normocytic? Is it hemolytic, or it is pancytopenia when all the cell lines are decreased? Now, what is reticulocyte count? Reticulocyte count is normal is 0.2 to 2%, and that is giving the response of what how the bone marrow is responding. So, and it is seen high bone marrow activity is seen in hemolytic anemia following acute blood loss and iron deficiency anemia on treatment. So, cause of anemia, as I mentioned earlier, could be identified by various investigations. So this you can see on the top, you can see there is iron deficiency anemia, and you can see the pictures of hypochromic and macrocytic. And then in the right side is thalassemia. We could see the target cells. Then you could see the blast cells, sickle cells. You can see in the case of sickle cell disease. So that is the blood picture is very important, because that would give you an idea what type of anemia is it, and then you will know how to treat that anemia. And also sometimes you could even see a malaria parasite on the blood picture. And in the bone marrow, if it's a aplastic anemia, then you can see that picture. So normal smear is normocytic, that is normal size of red blood cells, and normochromic, normal color of red blood cells. In the iron deficiency, as you can see in the picture, the microcytic, there is small red blood cells, they are hypochromic, there is pale, there would be variation in the size, anisocytosis, and variation in the shape, poikilocytosis, with or without the target cells. Malaria parasite can be seen. In the aplastic anemia, they shows either low or no count. Sickle cell, again sickle cells you can see. Toxic granulins can be seen, and abnormal blast cells in case of leukemia, and target cells in thalassemia. So what happens to the red cell indices? Because these are the indices which would tell us red blood cell count decreases in anemia. Then also the packed cell volume also that is less than 32. Mean corpuscular volume, which is low in iron deficiency anemia, because that is telling about the size, microcytic. Mean corpuscular hemoglobin also decreases, and MCHC also decreases, which is one of the most sensitive indices and for the anemia. That is a mean corpuscular hemoglobin concentration. Now, depending on these, first you see the blood picture, and then you get the indices. Then you would order, if you see this picture of iron deficiency, then you will order serum ferritin levels, serum iron levels, that would be decreased in case of iron deficiency anemia. Serum iron binding capacity, that would increase. Percentage saturation of transferrin decreases to less than 20% in iron deficiency anemia, and RBC protoporphyrin. Also, it can double or triple in iron deficiency anemia. But the last two are less prescribed investigations. The first three are the most common when we detect that it's a case of iron deficiency anemia. So again, these are the normal values, and you can see that in iron deficiency, all three are reduced. But MCSC could be normal if you are in some cases of thalassemia. So this is arranged with the normal values and what happens in the iron deficiency and in thalassemia. Other investigations we talked about, we could do the urine examination again to see if there has been any urinary tract infection, red blood cells or casts, stool examination to see any occult blood or ova, bone marrow examination if it's a refractory anemia or if you can see that all the cell lines are decreased, and X-ray chest, pulmonary tuberculosis, blood urine nitrogen or serum creatinine if you are suspecting any renal disease. Now coming up to the treatment for iron deficiency anemia. As we are talking about, we have talked about that iron deficiency, again most important is to improve the diet, and the diet should be rich in iron and fruits and leafy vegetables. Plus we need to treat the worm infestation, maintain general hygiene. Food fortification with iron and genetic modification of food is also an idea, like for example in wheat or in atta you can add some iron, or in other diet which is the staple foods you can add, and that's called the food fortification. Then iron and folic acid supplementations should be given in the young girls even before they get pregnant and especially during pregnancy. Heme iron is better present in the animal food and is better absorbed. Iron absorption, what are the enhancers of iron absorption? They are the citrus food, vitamin C. And what are the factors which decrease? Are the tea, coffee, calcium, phytates, phosphates, oxalates, and cereals with iron. Because usually with calcium and tea and coffee, these are the inhibitors of iron absorption. So we talked about these are the food which are rich in iron. So as we the iron supplementation in pregnancy is 60 milligram of elemental iron, 400 micrograms of folic acid is a daily requirement during pregnancy and 3 months thereafter. In anemia, the therapeutic doses are increased to 180 to 200 milligrams per day. The route of administration depends on the severity of anemia, gestational age, compliance, and tolerability of iron. This is very important. For example, if a lady comes and she's pregnant at about maybe fifth month, that 20 weeks, and you see that she has moderate anemia, her hemoglobin levels is 9 or 8 grams, so then you know that this she still has a time before she delivers, and if she hasn't started any oral iron, then you can prescribe her oral iron, and also then you can continue and you can follow. But for example, at this same gestation she comes with a hemoglobin of less than 4 or 5, maybe in the category of severe anemia, then obviously you would need to transfuse blood. So, and then for example, a woman who has been taking iron, in spite of that she is not able to tolerate iron, then you might need to give either intramuscular iron injections or intravenous to build up her hemoglobin levels and also to build up her stores. There are various preparations: fumarate, gluconate, succinate, sulfate, and ascorbinate. Oral iron can have side effects like nausea, vomiting, gastritis, diarrhea, and constipation. Iron supplementation usually we don't recommend the first trimester. It is usually given from the start of the second trimester. So oral iron, if there is hemoglobin, as we talked about 8 to 11 early pregnancy, then you can give oral iron. Contraindication would be if there is intolerance to oral iron, if there is severe anemia and advanced pregnancy, and the patient is non-compliant. How would you know if there is failure to respond? Then what do? You first have to see whether it was iron deficiency, or maybe it could be some like folic acid deficiency or B12 deficiency. So you have to see if your diagnosis was accurate, if there is faulty absorption, if there has been a continuous blood loss, coexistent infection, that's why the anemia is not being corrected, or if there is associated folate or B12 deficiency. The indicators of response to therapy would be feeling of well-being, improved look of patient, better appetite, rise in the hemoglobin level, and reticulocyte count will also rise in 7 to 10 days. That would give you the bone marrow response. Parenteral iron therapy, that is the iron sucrose, is the form which is given in the parenteral use, and the dose is calculated by a formula, that is weight in the kilogram of the mother into iron deficit. That is, for example, her hemoglobin is 8, so you would minus from 11, that would be 3. 3 multiplied by 2.2 plus 1000 milligrams for the iron stores. So that would give you the calculated dose. This and the response again by increase in the hemoglobin level about 1 gram per week, and also you could check from the retic count that it increases in 5 to 10 days, plus if there is increase in improvement in the clinical symptoms. Indications for blood transfusion would be if there is a severe anemia first seen after 36 weeks of anemia of pregnancy, but that could be earlier even also. Anemia due to acute blood loss, APH or postpartum hemorrhage, associated infections, patient not responding to the oral or the parenteral therapy, plus if she has any symptoms, severe symptoms like dyspnea with heart failure, then you need to transfuse blood. If the anemic woman comes in labor, then labor needs to be supervised. First of all, our aim should be that no woman should be anemic when she comes to labor room. If she is coming for regular antenatal checkup, then we need to advise her properly about diet, about iron therapy. We need to follow up by checking her hemoglobin levels, and good counseling is important. So when she's in labor, we are not worried about her. If there is a loss, then she would be able to compensate that blood loss if her hemoglobin levels are good. But for example, if the woman comes, then the labor should be supervised. Proper counseling and consent needs to be taken. Blood, whole, and especially fat cell should be arranged and cross matched. Women should be nursed in a proper position. Intermittent oxygen needs to be given. Precaution to prevent infection and blood loss. Strict aseptic precautions and minimal vaginal examinations during labor. Prophylactic antibiotics can be given, and IV line should be there, and IV fluids should be avoided or restricted. And in decompensated patient, you need to give diuretics so that she doesn't go into congestive heart failure. The second and the third stage of labor, second stage need to shorten by forceps or vacuum, because if she puts lot of force, then there is risk again that she can go into congestive heart failure if she has to push lot. So that's why the second stage is shortened by the instrumental delivery. Active management of the third stage of labor needs to be given. That is the oxytocin, and that has to be given, 10 units intramuscular stat, and then controlled cord traction and delivery of the placenta. Sometimes if there is risk that the mother could go, then we could keep the per-rectal misoprostol if needed after delivery. Methrogen is usually contraindicated. Even normal blood loss may be tolerated poorly in anemic patients. So you need to very carefully monitor the blood loss, and you need to have a blood arranged before this situation arises. And IV furosemide given after delivery to decrease the cardiac load. Postnatal early ambulation is encouraged. Hematinics are continued for 3 to 6 months. Watch for signs of any subinvolution, purpurial sepsis, congestive heart failure, thromboembolism, and lactation failure. Avoid pregnancy at least 2 years, and you need to counsel about different methods of contraception which can be used depending on what the couple wants. So here are some MCQs. I think you would be able to solve them after we have had a detailed talk on anemia. So when would you say considered mother is anemic? When her hemoglobin level is below and I would like you to answer and then recheck from your lecture. Most common cause of anemia in pregnancy in India is iron deficiency anemia can be diagnosed earliest by which laboratory test? Response to anemia management by oral iron therapy in pregnancy can be assessed earliest by which complication is not common in pregnancy with anemia? Now coming up to the next type of anemia, that is the macrocytic anemia. So in the macrocytic anemia comes usually two things, folate deficiency and B12 deficiency. First we will talk about the folate deficiency. Folate requirement increases in pregnancy as all tissues require uh, folate for the manufacture of DNA. Normal values of folate concentration fall in pregnancy due to hematological effect of plasma expansion. Also, we need to use the folate supplementation to reduce the neural tube defects. Other causes would be the B12 deficiency, and also if there has been increased alcohol consumption by the mother during pregnancy. Now coming up to the types to the hemolytic anemia, these are there is defect in the production of the alpha or the beta chains of hemoglobin, resulting in the imbalance in the globin chains, which leads to ineffective erythropoiesis and hemolysis in the spleen or the bone marrow. Clinical manifestations and treatment depends on specific gene and number of alleles affected. Common features: increasing severity with increasing number of alleles is involved, hypochromic macrocytic anemia, basophilic stippling, abnormal shade red blood cells on blood film, and these are common in people of Mediterranean and Asian descent. Now the pathophysiology of the hemolytic of the thalassemias. So the thalassemia is a group of inherited blood disorders where the hemoglobin is abnormal as a result of mutations in the gene that code hemoglobin. They are inherited in autosomal recessive pattern. Although thalassemia can occur worldwide, the carrier rate is particularly common in people from Southeast Asia and also affects those of Mediterranean, North African, Middle Eastern, Indian, and Asian origin. A mutation that affects the alpha chain causes alpha thalassemia, and beta thalassemia occurs as a result of mutation in the beta chains. Now, the alpha chains, they are produced by 4 genes, 2 on each chromosome 16, and these are inherited as pairs. Now, the severity of the condition depends on how many of those genes have altered. If out of 4 only one gene is mutated, then the women are usually asymptomatic. If women carry 2 mutations, alpha thalassemia trait, they may have mild anemia. Hemoglobin H disease occurs when an individual carries 3 mutated genes, and they will lead to chronic anemia that requires regular blood transfusions. Alpha thalassemia major occurs when all the 4 genes are mutated and is associated with a high incidence of intrauterine death. In the coming up to the beta genes, there are only 2 beta genes, one each on chromosome 11. The beta thalassemia phenotype can range from moderate to severe. Beta thalassemia major occurs when both the beta genes are affected, and affected individuals will require blood transfusions for the rest of their life. Beta thalassemia intermediate is a milder form of the condition and is non-transfusion dependent. Also, I mentioned about the fetal hemoglobin. The fetal hemoglobin, that is the hemoglobin F, there are 2 genes, alpha 2 and gamma 2. But then in the adult, it switches to hemoglobin A, that is the alpha 2 and the beta 2. And we talked about that. In the hemoglobin A, that is the adult hemoglobin, is 97% is hemoglobin A and 3% is hemoglobin A2. So we have been talked about alpha thalassemia, and usually fetuses develop marked hydrops and pregnancy is complicated by polyhydramnios and preterm delivery. And also it is affected by severe preeclampsia, no treatment until diagnosis in subsequent pregnancies. Again, the beta thalassemia is due to defects in the normal production of the beta chains, and show if there is a doubt that all pregnancies should be offered hemoglobin electrophoresis for the diagnosis of these thalassemia. So women will have low MCV, but usually it is seen that MCHC is also low in cases, is normal in cases of thalassemia. Iron and folate supplementation should be given and their partners should be screened. If both partners have thalassemia minor, then 1 in 4 chance of that the fetus could have thalassemia major. Now we come up to the sickle cell syndromes, and that is the sickle cell disease. It is three, and then sickle cell trait, sickle cell hemoglobin C disease, that is hemoglobin SC, and other autosomal inherited disease. So these are again the different forms of hemoglobinopathies. So sickle cell disease is basically an autosomal inherited genetic where abnormal hemoglobin S contains beta globin chains with an amino acid substitution that results in its precipitating when in its reduced state. What happens then? The blood cells become sickle shaped, as have been shown in the slide before, occlude the small blood vessels. There is severe anemia, chronic hyperbilirubinemia, and predisposition to infection, vaso-occlusive complications, including the acute chest syndrome and chronic kidney disease. And so it has very high mortality. Advances in the treatment of sickle cell disease have resulted in average lifespan in the Western world extending to up to 50 years, which means many more women with conditions are now becoming pregnant. Like other medical disorders, ideal management begins with the pre-pregnancy optimization. So in the antenatal period, you are going to give education to the mother regarding her health, and also high dose folic acid supplementations, 5 milligram daily, are usually recommended. And sometimes a woman might need to be given low dose aspirin. Pregnancy is associated with an increased incidence of sickle cell crisis that may result in episodes of severe pain, typically affecting the bones or the chest. The acute chest syndrome may result from an initial uncomplicated crisis and is responsible for around 25% of all deaths of sickle cell disease. So, this is because of the sickling. The crisis is precipitated by hypoxia, stress, infection, and hemorrhage. Mothers are also at increased risk of miscarriage, preeclampsia, fetal growth restriction, premature labor, with 3 times risk of eclampsia compared to women who do not have sickle cell disease. Also, it has been seen that there is risk of fetal growth restriction. Thromboembolic events including cerebral venous thrombosis and deep venous thrombosis are also seen. There is higher rates in sickle cell disease. So we have been talked about how would you do screening at booking, and if there is uh, uh, positive sickle cell disease, then again offered counseling and prenatal diagnosis also, so that to see if the baby is not affected. Prevent sickle cell crisis by avoiding hypoxia, dehydration. Hemoglobin levels should be maintained above 10 grams per deciliter. Aim would be vaginal delivery with epidural anesthesia and monitoring labor, especially, and also to advise contraception. So one more thing, that sickle cell hemoglobin C disease may cause only mild degree if there is hemoglobin C disease, and it is associated with very severe crises that occur more often in pregnancy. In this condition, women are not as anemic as those with SS disease, and the severity of crisis may be underestimated. The ones who are sickle cell carriers again have a 1 into 4 risk of having a baby with sickle cell disease if the partner also has a sickle cell trait. Carriers are usually fit and well, but they are at increased risk of urinary tract infection, and they also rarely suffer from crisis. Now we talk about thrombocytopenia, that is defined when the hemoglobin level is below 150 times 10 grams per deciliter. And so there could be incidental finding for example, on just the lab, or sometimes the woman could present some symptoms like she could have any purpura or petechiae on the skin. The causes are again incidental thrombocytopenia, or there is increased consumption of platelets. There is autoimmune thrombocytopenia. There is activated clotting mechanism. Sometimes thrombocytopenia is associated with preeclampsia, HELLP syndrome, and DIC. Platelet thrombus formation, hypersplenism, or decreased platelet production. So before I end, just wanted to give you more important things, that in pregnancy it is very important if there is has been a case of thrombocytopenia, so we need to have a liaison with the hematologist as well. First of all, we need to see what could be the causes, again from the history and examination and investigations, and then we would monitor the pregnancy to check the platelet level, and then we need to decide what time we need to deliver. Sometimes we need to arrange the platelets, transfuse platelets, and then induce the mother and deliver her. And during, if there is a case of autoimmune thrombocytopenia, then sometime we need to give steroids so that the platelets levels are being increased and the mother can be managed. Also, some the steroids can be given in the dose of 40 to 60 milligram prednisolone, and because they will suppress the platelet onto auto antibodies. Sometimes it need to be given about 2 to 3 weeks. If it is not effective, then intravenous immunoglobulin IgG has to be given in case of autoimmune thrombocytopenia. Again, vaginal delivery is usually facilitated, and usually the regional anesthesia is avoided if the platelet counts are below 80 into 10 to the power 9 per liter. Fetal blood sampling or instrumental delivery is also avoided. So this is all about anemia, and also we talked about other hematological conditions along with anemia, that was thalassemia, sickle cell disease, and thrombocytopenia. Thank you very much.